Refractory anemia is a problem for diagnosis and treatment for all the practicing pediatricians. Dr. Nitin Shah is an expert hematologist, pediatric hematologist from Mumbai. He will explain the causes and management of refractory anemias in children. Over to Dr. Nitin Shah.
Thank you, Dr. Joshi, and the organizers for inviting us to this beautiful venue. And welcome early morning. I really admire your enthusiasm when half of us would be actually in the bed on a Sunday morning. You are here to learn something. And at times we have cases in hematology which look so complicated. But if you actually carefully look at the basic investigation, which is CBC, red tick and peripheral smear in an anemic child, you get a lot of clue based on the clinical scenario. And if you only understand how to interpret the CBC vis-a-vis the clinical scenario, then I think half or more than half the time you are able to solve the problem without advising too many complicated tests. So let's see how to solve this in patients who come with so-called refractory anemia. Now I must tell you here that by definition, refractory anemia means myelodysplastic syndrome by adult definition. That is very rare in children. And there are 5 types of refractory anemia with sideroblasts, without sideroblasts, etc., in crisis, in blast, and a full-fledged AML. I am not going to discuss that because that's very boring. The term refractory is used very loosely by consulting pediatrician, which actually would probably mean that they have given iron, folate, B12, and the patient is not responding. And now they don't know what to do. And there are no other clinical clues like frank leukemia or frank hepatosplenomegaly, etc., which makes it so difficult to diagnose, say, thalassemia or malignancy and so on and so forth. And because the title given to me is beyond iron deficiency, I will pick up 3 or 4 cases of microcytic hypochromic anemia which are not iron deficiency in that sense. Let's start with case number 1. And I can always stop when the time is over because, I mean, this is an endless game. And maybe if some of you, especially I see some postgraduates probably, they can try to interpret, volunteer and try to interpret. Okay, it's simple, it's iron deficiency, the slide says. The child looks pale. You can see she's pale both in tongue and in the conjunctiva. 5-year-old female child, pallor since 1 year of age, so very early in life anemia. There is no suggestion of what the cause is, like there are no worms, there are no bleeding, no diarrhea. She has been hospitalized in past for some lower respiratory infection and fever 3 to 4 times. But that is something that you see in the community so often. Now, so many people are misdiagnosed as pneumonia and admitted for 2 days, given some antibiotic. To me, they are all viral infection, and they are very common in children. She has been diagnosed as iron deficiency anemia in past, treated with oral iron, but she needed transfusion once so far. When you need transfusion in a child for iron deficient anemia, you must think that maybe it is beyond the dietary cause of iron deficiency anemia, at least if not, that it is not an iron deficient anemia at all. Born of a consanguineous marriage and there are no history of transfusion in the family members. Now, in hemato-oncology as also in neurology, consanguinity is very important. When you have consanguinity, especially close consanguinity, you must think that it may be some inherited cause of the disease, especially if you are dealing with a complicated case. So the clue here is very early onset, diagnosed iron deficient not responding, and born to consanguineous marriage. Okay, she is 13 kilo with 107 centimeter height and she is pale. She has just palpable liver and little palpable spleen, and there is nothing else in the examination. So what clues from examination? 5-year-old, 13 kilo, low, very low, height 107 at 5 years, low, so she is stunted and not grown well, and she has some hepatosplenomegaly. Now this is the CBC with which she comes to us. Can anyone volunteer to interpret this CBC? Or for the lack of time, I will do it for you. Okay, look series by series when you interpret CBC. So first RBC series, hemoglobin is moderately low. What is driving that low hemoglobin? Look at the MCV. For 59 is gross microcytosis. Look at the MCH, gross hypochromia. When you have microcytic hypochromic anemia, you look at the RDW. RDW is high, it means dietary or iron deficiency. RDW is normal, it can be thalassemia minor. RDW is high, so it is iron deficiency. Like picture, platelets are normal. Now you always confirm what you see on the counter report by looking at a smear, and I cannot press upon more to say that a peripheral smear is a more important test than any sophisticated investigation you do on an instrument. Peripheral smear does confirm it is microcytic hypochromic anisoovalo. When you have microovalo, it's iron deficiency. When you have macroovalo, it is megaloblastic anemia. When you have micro without ovalo or macro without ovalo, it's unlikely to be nutritional cause. So that's another lesson learned. All right. Because she's 5 years and she has been diagnosed and treated in past, she's not responding, you will want to confirm iron deficiency state in this child. So you do serum iron TIBC, the transferrin saturation is 50%, that's high. So also the ferritin which is high. So definitely it's not iron deficiency per se, right? Investigation done for chronic anemias like infection, MANTU negative, X-ray test normal, all organ function, thyroid test, electrophoresis, everything is normal. Now you have something is behaving like iron deficiency, but is not iron deficiency. So that makes it in that sense refractory. So remember when we have this table of DD or microcytic hypochromic anemia, we have iron deficiency anemia, you have anemia of chronic disease, you have combination of iron deficiency with chronic inflammation because of recurrent infection in children, and you have thalassemia minor. These 4 things, and you know this table how to differentiate. Ultimately the differentiation will be by ferritin and by electrophoresis, and it should be fairly simple to clinch the diagnosis. So we have a child who is born to consanguineous marriage, looks like some inherited cause, behaving like iron deficiency but is not iron deficiency, also has some organomegaly which goes against iron deficiency, needed transfusion once, which again is not like dietary deficiency, and has high ferritin. So you do a bone marrow in such child, and when you do a bone marrow in such child, always ask for iron staining. Any marrow for anemia must be subjected to iron staining. This child's marrow was cellularity normal, erythroid hyperplasia, myeloid series normal, megakaryocytes normal, everything else was normal. So it was labeled a normal marrow with erythroid hyperplasia, which is like in any child of anemia. We asked for iron staining, and the iron stain is positive. What does it show? Ring sideroblasts. Okay. So now everything is fitting into congenital sideroblastic anemia. So remember, when you are studying in your Nelson's textbook or hematology textbook of Nitin and Oski, this is the 5th cause which we never look into. We think that's so rare, okay, we are not going to see it in our lifetime. Let's concentrate only on iron deficiency, let's concentrate on anemia of infection. So the 5th cause is that sideroblastic anemia, which will come with low hemoglobin, low MCV, but it will have many times high ferritin, and you do a marrow, and marrow will show you ring sideroblasts. So all that is microcytic hypochromic is not necessarily dietary or true iron deficiency anemia. So congenital sideroblastic anemias are usually X-linked, sometimes they are autosomal recessive with this particular mutation. The treatment is simple, you give pyridoxine and 80% of them would respond. So no very complicated treatment is required. This patient was started on 75 milligram of pyridoxine per day, anemia got corrected, liver spleen regressed, growth improved, and infections become much less because the anemia improved. Okay, now let's look at the second case. This child looks like thalassemia from the faces or a hemolytic faces. 10-year-old female child, she's pale since 3 years of age. That means again very early onset of anemia. She has jaundice off and on. Now when you have anemia with jaundice, always ask for, is it choluric or acholuric? Choluric, dark urine, bile pigment, liver diseases. Acholuric, not dark urine, that means it's hemolytic or indirect hyperbilirubinemia. She has got some failure to thrive, and that's it. So some recurrent jaundice, pallor since very early, and failure to thrive. She has been needing transfusion once in 4-6 months. So she is what you call transfusion dependent anemia. She keeps hemoglobin at around 5 to 9, that's very, very low or moderate. Again, consanguineous marriage, that's very important, and there is no history of transfusion in the family. So first is in examination, and you see that she is stunted, and she also has very poor weight. She is pale, she is icteric, and she has gross hepatosplenomegaly. So far the diagnosis would be thalassemia intermedia, like picture, maybe double heterozygous, maybe homozygous, but with milder variety. So you ask for CBC. Hemoglobin is low, 7 gram, WBC is high. When you see high WBC in a patient with suspected thalassemia-like syndrome, the high WBC is because of the presence of nucleated red cells which are counted at WBC by the counter. So always look at the smear and correct the WBC count for the number of NRs that you are seeing for 100 WBC. So probably my feeling is this will be having NRs, low MCV, low MCH, low RBC count. You do a smear, it shows microhypo, aniso, ovalo, poiculo, broken cell, typical of a thalassemia intermedia or thalassemia major like smear, what do you call a variegated smear. You do iron studies, grossly high ferritin, so obviously this is not iron deficiency, and so far there is no suggestion also. But she's got microcytic hypochromic picture. LFT is normal, bilirubin is high, but indirect is high. So this so far looks like thalassemia intermedia syndrome. How will you now diagnose? You will ask for hemoglobin electrophoresis of the child and the parents. This is the hemoglobin electrophoresis of the child and the parent. Patient HbF is normal. Now you can have low HbF in a thalassemia major or intermediate if she is recently transfused, but this child was transfused more than 6 months back. HbA is normal and HbA2 is high, 4.8%. So she is beta thalassemia carrier, right? Now you do parents. Father is beta thalassemia carrier as A2 is 4.5%. Mother is normal, she is not beta thalassemia carrier. So behaving like thalassemia intermedia, child is thalassemia carrier, father is thalassemia carrier, mother is normal, so child cannot be major or intermedia because she needs 2 gene defect and she has only single gene defect. How do you explain a thalassemia intermedia phenotype in a patient who has got thalassemia minor on genotype? Now if you remember, why does a thalassemia major have hemolysis at all? If suppose beta chains are absent, you can make more gamma chains and you can compensate, but their compensation is never complete. Second thing is, why does hemolysis occur at all in thalassemia major? Remember, it is the imbalance between alpha and beta chain that leads to precipitation of hemoglobin and breakage of that RBC or nuclear red cell while in marrow. That's known as ineffective erythropoiesis. So if you have thalassemia major, you have absent beta chain, so you have 2 alpha chains and 0 beta chain. Imbalance leads to more alpha chain, which precipitates leads to hemolysis. Very simple. In thalassemia minor, there is 50% beta chain, which is enough to compensate. So if at all they are mildly anemic. Now how can a beta thalassemia carrier become hemolytic? Is when alpha chains go up. So normally you have 2 alpha chains, suppose it becomes 3 alpha chain. Then again there is imbalance because there are 3 alpha and only 1 beta in a thalassemia minor. It is like same as 2 difference of 2 in thalassemia major with 2 beta, 0 beta chain and 2 alpha chain. How can you have more alpha chain? So for that you have to know genetics of alpha chain. Normally you have beta chain is 2 pairs, alpha chains are 4 pairs. There are 2 on mother's side, 2 on father's side inherited. What if you inherit 3 from mother and 3 from father? That's known as triplication of alpha chain. So when you have this type of phenotype, the next thing you will ask for how many alpha chain this patient has and why does this patient need transfusion and why does this patient behaving like thalassemia intermedia. So we ask for alpha chain analysis and this child had triplication of alpha chain. Genetic study event reveals triplication of alpha gene imbalance leading to hemolysis. So she is thalassemia minor but behaving like thalassemia intermedia. Okay, we move to case 3. She is iron deficiency but not responding to iron. 8-year-old female child, pallor since 2 years of age, so very early in life she is pale, not growing well. She has got diarrhea and cramps in abdomen as a child and there is no other suggestion of what the cause of anemia is, like in the form of no worms, no bleeding, no fever. She has been treated with oral iron vitamins in past but there has been not much response. She hails from Rajasthan and she is not born of a consanguineous marriage. So all that we have on history is a chronic anemia in a child with some diarrhea in past, treated with iron, not responding and hailing from Rajasthan. She's weight is 18 kg and height is 107, which is very, very low for an 8-year-old child. So she has got obvious failure to thrive and she is pale. She has got just palpable liver and spleen, which may be there in any chronic iron deficiency anemia. And there is no icterus, no other thing on the systemic examination. Now this is the CBC. Again, hemoglobin grossly low, severe anemia. What is the cause of the severe anemia? MCV is 45, so that's very low. MCH is 18, that's very low. RDW is high, that's very high. So she is behaving like a typical severe iron deficiency anemia. You confirm by smear showing you micro, hypo, aniso, ovalo, as we said before. You order serum iron, TIBC and ferritin. And this time, transferrin saturation is just 2% and ferritin is just 5 nanogram. That means it is grossly low. So she is iron deficient, there is no doubt about that. Her electrophoresis was done in past was normal and all other examination was normal. If she is iron deficiency, then why is she not responding to adequate dose of oral iron in the past? So when you have a patient of iron deficiency not responding to oral iron, what do you check for? Check for the salt. It should be good salt, ferrous sulfate, ferrofumarate or ferrous ascorbate. Correct dose. So 3 to 6 mg per kg per day in 1 or 2 divided doses. Compliance, check the number of pills and number of bottles the parents have used, because many times they may say I have given, but they actually don't give it, or the child may throw it away. So all that is first to be done before you do further investigations. So 8 years is not the typical age for nutritional iron deficiency. She is grossly stunted, as you can see here, for the height. She had some diarrhea in the past. She is from North Indian ancestry, that is hailing from Rajasthan. Poor response to iron. You must think of secondary causes of iron deficiency, which includes polyps, bleeds, malabsorption and Meckel's. So first thing you will do when North Indian ancestry is to look for celiac disease. So of course you will do stool for occult blood for 3 to 5 days. If it's negative, then you would do for the malabsorption, especially when she had chronic diarrhea. So her anti-TTG comes positive. Now what about screening test? When you do screening test for celiac, you should do anti-TG, IgA, IgG, and also do total IgA, because if the patient is total IgA deficient, your anti-TTG, IgA may not be positive. It may still be celiac, in which case you will need a brush biopsy to diagnose. You will do a jejunal brush biopsy, which will show you villus atrophy. You put the child on gluten-free diet and give then IV or oral iron, and the patient responds and has a very rapid pickup in the growth. That also proves you that that's celiac disease. So remember, North India, I don't know how common is celiac in South, but in North it is very common to find this type of children. Okay, the fourth case about this microcytic hypochromic anemia, till I go to the last case, which is macrocytic anemia. To be or not to be iron deficient, that's the picture. This is a small cute child looking at you for your help. 5-year-old female child has pallor since last 2-3 years, has cough and cold off and on. There is no worms, bleeding, diarrhea or fever to say what the cause of anemia is. She was diagnosed as iron deficiency because she had microcytic hypochromic picture and was treated with adequate oral iron like the previous child, but she would not respond, and in fact she would sometimes become symptomatic, needing transfusions 2 to 3 times so far. So as I said before, if you need transfusion for iron deficiency, that is not dietary iron deficiency anemia. Born of a non-consanguineous marriage and there is no transfusion history in the family. So all you have is a child with recurrent cough cold, pallor, not responding to iron and needing transfusions. Is failure to thrive in the form of low height and low weight. She's got pallor, no icterus. There are some rales and rhonchi to suggest some respiratory illness, and rest of the examination normal. There is no hepatosplenomegaly or no lymphadenopathy. Now this is the CBC. HB is 5.5 with a low MCV and a high RDW, behaving like iron deficient anemia. Normal WBC, normal differential, and a platelet count which is high, again which is like an iron deficient anemia. Now she's got micro hypo aniso ovelo, and again you order for serum iron TIBC. Saturations are low, ferritin is low, so this is iron deficiency, but she has not responded to iron and she has needed transfusion in the past. So again, as we said in the previous child, you have to think of a secondary cause of iron deficient anemia in the form of malabsorption or bleeding. So it is IDA, it is secondary because the age is not the correct age, the diet is good and there is no response. So two things you have to think of is either problem in absorption like the previous celiac child, or loss of iron somewhere in the body or outside the body. Now there is no external bleeding to say that he is losing iron outside, it has to be loss of iron somewhere inside. Now with the history of recurrent respiratory infection, first thing you would do is XRHS PA, and even if the XRHS PA is normal, you would order for a CT scan, look at the of the lungs. So malabsorption, celiac disease was ruled out, worms, giardia, treatment given but no response. Losses could be in GI, so you do stool for occult blood, that was negative. Respiratory could be pulmonary hemosiderosis, urine in hemosideruria, and sometimes hematomas which may not be obvious, but there may be juvenile polyps which are bleeding every day, which will be picked up by doing a stool for 4 to 5 days, where one day it will come positive. So this child X-ray was done which had shown bilateral fluffy shadows, you can see here, and a CT which showed that there are nodular opacities which are spread all over the lung. The next you would do is a BAL. So we did a BAL in this child and stained for iron, and we can see iron stained macrophages. So this is a case of pulmonary hemosiderosis. Most of them are primary. Of course, you will do a 2D echo to rule out pulmonary hypertension for whatever cause. Most of them are primary. They are many times immune arthritis. Sometimes you may not see any immune workup, also may be negative. And all you need to do is actually after the workup, if you find idiopathic hemosiderosis, try to treat them with steroids, and many of them would respond to steroid, and you are able to taper the steroid and then put them on steroid or cyclosporin or something like that, an immune modulator, so that the bleeding stops and the patient becomes okay. Now that's the last case. We have 3 minutes, sir? 5 minutes, okay. So this is a child, this says megaloblastic anemia. Okay, 3-year-old female child had congenital hearing loss and was evaluated for cochlear implant. Of course, this is too late in life. Someone should have picked them up in the first 6 months. And I know Kerala has a hearing as a routine test for newborn screening, and I am happy about that, but that's not the case in most of the part of the country. Now, when she went to the public hospital where she was evaluated, she was found to be anemic. So she was asked to refer to a pediatrician and find out and treat the anemia before they can operate. She had history of breath holding spells off and on in the past. She was born full term with 3 kilos, born to a second degree consanguineous marriage. Now she was pale since the age of 7 months as per the parents, and she had needed transfusion in the past. Now again, that's a history which is not typical of an iron deficiency, even when breath holding spells actually tell you that this could be an iron deficiency child. CBC at 7 months was showing you hemoglobin of 2.1 gram. That's really grossly low. You don't become 2 gram with iron deficiency at 7 months. You become 7 gram, 8 gram, something like that. WBC was normal, platelets were adequate, and she had some micro, macro, and teardrop cell. Her serum iron studies done that time were normal, and her electrophoresis done that time was normal. Now, these are the serial CBCs from the whatever little paper the parents could bring, that she used to have somewhere in 2008, 5 gram, then 5.4, 6, 6.7. She had only one complete CBC report, which was in October 2008. We had shown that the MCV is 92.6. That's not microcytic hypertension. This, if at all, is little more. We take 85 or 90 as the cutoff, or sometime 95. So this is a little high. And she has a normal WBC, but a little low platelet. So she had anemia. She had low platelet, so bicytopenia that time. So at Hinduja Hospital, when she came to us, we did a CBC which showed hemoglobin of 7.6, a normal WBC and differential, low platelet of 95, and an MC which was 94.7, which was high with a low retic. So she had bicytopenia in the form of low hemoglobin and low platelet. Her other investigation I've reviewed, G6PD done was normal, ferritin was normal, osmotic fragility was normal, thyroid profile was normal. With the picture of bicytopenia with high MCV, a bone marrow examination was done to rule out some megaloblastic anemia or whatever the cause of anemia is. Now, unfortunately, this procedure was done on OPD basis. The patient never followed up with bone marrow report and was lost for follow-up for 1 month. Meantime, she got admitted back to that public hospital where the report of bone biopsy was read by the hematologist, who was an adult hematologist, and the biopsy had said suggestive of myelofibrosis. Now, in presence of teardrop cell, normocytic anemia and a myelofibrosis, the adult would always think of a primary myelofibrosis as the diagnosis. So that child was put on steroids by the hematologist on 1 gram per kilogram per day for 1 month. Now, while this was happening, she developed polyuria, listlessness, severe steroid phases, hypertension. They did a random blood sugar which was very high, 349. They tried to rule out a juvenile diabetes or a infantile diabetes, but insulin levels and GAD antibodies were not suggestive of an immune destruction, which is so typical. So anyway, they thought it's steroid-induced diabetes, so they started tapering the steroid and stopped the steroid and started the patient on insulin. Now, even off the steroid for a month, she still had sugars which are 200, fluctuating up to 200, and was behaving like a true diabetes, not steroid-dependent diabetes. So patient returned to us because she's not getting better, to say what's happening with the child. So when we think, what do we have? We have persistent refractory anemia, we have congenital bilateral sensory neural deafness, and she had diabetes mellitus, which was ascribed to steroid, but it's actually not, and she's insulin-dependent diabetes mellitus. Now, anyone who has a smartphone and is not seeing YouTubes and WhatsApp all the day, but once in a while also looks at UpToDate or one of these medical sites, and you put refractory anemia, congenital deafness, and diabetes mellitus, it will give you diagnosis there and there. So, bone marrow slides were reviewed by it, had shown megaloblastic changes. So, she had not only persistent refractory anemia, she had persistent refractory megaloblastic anemia. So, we thought of thiamine responsive megaloblastic anemia in this child. All you need to do is give thiamine in mega doses, 75 milligrams. She was started on that. In a month's time, she was off insulin. The sugars became normal. The hemoglobin became normal. Mind you, the deafness will never become normal because the deafness is a damage in utero to the hair cell which will never respond. We had sent these childs, that time this next generation sequencing from MedGenome and other labs were not available in our country. This is in 2008, you can imagine. So I had sent a sample to USA in Boston Children's Hospital, and the Dr. Neufeld, who actually did the test free for us, said that the patient is homozygous for this mutation, which is typically seen in patient with TRMA or the thiamine responsive megaloblastic anemia. These children not only have anemia, diabetes and deafness, but they can also have cardiopathy and other like ophthalmic damage. We did all that, everything was normal. Unfortunately, we lost the child in follow-up for family dispute, but in any case, something which is treatable as simple as with thiamine was actually doing rounds from one place to other place, having trouble. So what are the take-home messages from these 5 cases? Take a proper history with origin, duration, progress. Consanguineous marriage and deaths in family tells you it is some inherited cause. Detailed head-to-toe examination, short stature, deafness, failure to thrive, they were all pointing fingers to some diagnosis. Basic screening test, peripheral smear, X-ray chest in the child with nodularities would tell you straight away that you are dealing with some chronic lung disease like a patient with hemosiderosis. Look at the reports of the test order, ferritin, bone marrow, and the child never followed up with bone marrow, otherwise we would have picked up that TRM a little earlier. You do confirmatory tests as required, like BAL we did in that pulmonary hemosiderosis or anti-TTG in that celiac disease, and sometimes the disease can evolve like the TRMA, but most of the time you are able to diagnose them based on the simple test before you actually end up doing fancy of tests and make the patient spend. At the end you feel so miserable that something could be diagnosed on a peripheral smear. Thank you very much for your patient hearing.